السلام عليكم ورحمة الله وبركاته. Thank you very much for the kind invitation, kind introduction. I had a chance to sit down a bit in the last part of the standalone of AstraZeneca, and I was amazed at how much change has happened in lupus. So all of these new medications, I basically didn't heard about it. I finished Germans in 2009. So I hope you can bear with me. I'm going to take you back really, and you'll see that the only medication we have is the old friend, warfarin for that. But there has been a lot of changes, and I think all of you must have read it, because as a hematologist, I read it, and I'm following the EULAR guidelines for classification of lupus. So we'll go through it a bit. So introduction, as rheumatologists, all of you know that it's an autoimmune disease, basically characterized by venous or arterial thrombosis and pregnancy, morbidity in the presence of persistent laboratory evidence of antiphospholipid antibodies. It's really a very difficult diagnosis. It's not that easy to make of all of the testings available currently, and I'll show you what we do in the labs basically. So prevalence, something between 40 to 50 per 100,000 people. It's not that common, to be honest. Female predominance of 5 to 1 to males. 15% of patients with this SLE have antiphospholipid antibodies, in which case the disease is associated with organ damage and more complicated course. So the pathophysiology, I'm not going to dwell too much about it, but it's really around the endothelial cells and the beta-2 glycoprotein antibodies that attach to them and cause endothelial cell injury, and by that promoting thrombosis and activating the coagulation cascade on their surface. With that activation also, there's activation of platelets, with some of these patients will have thrombocytopenia, apart from developing autoantibodies against platelet, causing similar picture of ITP in these patients. Same thing can happen in pregnancy, where these beta-2 glycoprotein antibodies beta-2 glycoprotein antibodies will attach to the decidual cells or trophoblasts and cause ischemia and poor pregnancy outcomes ranging from intrauterine growth retardation, early pregnancy, preeclampsia or eclampsia, and sometimes intrauterine fetal death. So this is an old paper, but looked at the largest cohort of 1,000 patients of antiphospholipid syndrome, looking at what was the most commonest presentation. And if you can see, so DVTs were basically the most commonest, followed by thrombocytopenia, livedo reticularis, and for the longest time, these common presentations were never in the clinical criteria. If you look at fetal loss or poor pregnancy outcomes, it really comes down. It's rare, but just because it happens in pregnancy, that's where its importance comes up. So the diagnostic criteria, for the longest time, we've been using the revised Sapporo or Sydney criteria, if you may. And though it's a busy slide, I didn't dwell too much on it because it has been probably changed by now. So we used to look at clinical outcomes, whether it's vascular, so thrombosis, arterial, or venous, and look at or having poor pregnancy outcomes, and they were relatively nicely defined before. Laboratory criteria are still there, and we still use these criteria even with the 2023 update. So you needed to have one clinical criteria, whether vascular thrombosis or pregnancy outcome, as I mentioned. And probably in 2019, 2020, these were the proposed additional criteria that the EULAR group was working on at that time. The laboratory criteria, so all of you order lupus anticoagulant, and I'll show you in the next slide how difficult it is to do that actually. A much easier part is the anticardiolipin antibodies and the beta-2 glycoprotein 1 antibodies, because they are basically ELISA-based. They're not affected by anticoagulants. They can be done at any time. We do measure the IgG, IgM, although with the caveat knowing that IgM antibodies probably are least thrombogenic, are least pathogenic. Nonetheless, they are still mentioned in the criteria, and we still use them. So we did have separate ISTH recommendations on how to test for the lupus anticoagulant. So once you do that, you usually get a result, whether it's positive or negative. If you're in our center, unfortunately, we get results saying that weakly positive or moderately positive or strongly positive, which again, the ISTH has, International Society on Thrombosis and Hemostasis, has recommended to either be positive or negative reporting that way. Unfortunately, I haven't been able to change the mindset of my lab until now. So what's lupus anticoagulant? It's a three-step testing. So we actually do in the beginning a test making sure that there are antibodies, meaning there are lupus antibodies. So basically we do a DRVVT test, which should be insensitive to other antibodies. We confirm that with a PTT sensitive to lupus antibody reagents. Then the second step is the mixing study, which all of you know that it should be prolonged. After that, the third step is repeating the same test, but with enrichment with phospholipids. So basically getting all the antibodies attached, and that will correct. So it's a three-step testing. It's very troublesome. You cannot do these. All these three tests are based on clot formation. So that's why when we get the patient with an unprovoked DVT or PE, we immediately send the lab for lupus anticoagulant before we start any anticoagulant. Once the patient is on any anticoagulant, this test is completely invalid. So that's very important. Occasionally you get a patient with massive pulmonary embolism, he's hypotensive, and you're suspecting that he may have catastrophic antiphospholipid syndrome. I have seen those cases, and unfortunately, the blood sample for the lupus anticoagulant was sent after he was started on an anticoagulant. It's completely invalid after that. So that's very important to remember to draw the sample before anticoagulants. So this is the same step things. So we had limitation in the Sapporo criteria. It did include other manifestations, as I have mentioned before, thrombocytopenia, heart valve disease, livedo reticularis, excluded patients with pre-existing other thrombophilias, for example, factor V leading prothrombin gene mutation, and they really needed a bit more clear definitions. So late in 2023, we got the published classification criteria, and their goal was to achieve a high specificity relative to the revised Sapporo criteria to improve homogeneity in APS research. It's a very strong caveat. All of us in different diseases, we use these classification criteria as diagnostic criteria, which shouldn't be done. I didn't mention, but if you go through this paper, they make a lot of distinction between classification and diagnostic criteria to start with. So in the beginning, the patient need to have entry criteria, which is either having some clinical evidence of thrombosis or pro-pregnancy outcome and having a positive antibody. After that, it's a scoring system. I think there's already applications where you can calculate this. It's really bothersome, but once you get used to it, it doesn't take 30 seconds probably. It's really nice. As you can see, they have added thrombocytopenia. They've added pulmonary hemorrhages, which some cases only present with pulmonary hemorrhages, unfortunately. And they have added some skin manifestations, just honestly, I never knew before, so I ended up looking up the pictures. So livedoid vasculopathy or livedo race Mohs, basically small vessel capillary thrombosis in these patients, and that's how they look at. These are calculated in those scoring system. I have used it in certain patients where unfortunately a VTE has occurred, so DVT or PE, in a provoked manner. So there was a clear reason why the patient developed it, but someone sent for the antiphospholipid workup, and it was positive. So really the question comes up, does this patient need lifelong or not lifelong? So if you follow these criteria, actually he came low risk or even didn't meet the full scoring system. You need to score at least 6 points throughout this criteria, and that was helpful. In regards to their outcome, yes. So they compared it to the revised Sapporo criteria, and it showed much better specificity in the newer criteria. So it was validated retrospectively and also in another cohort as well. So that's what we have at the moment, and I think most of you are using it. I definitely started using it since it came up. Most of the hematologists are using it as well. So what about the lupus antibodies, the 3 antibodies we have mentioned? People can have 1 or 2 or 3 of them, and they interact. And what's interesting, you need to confirm these antibodies after 12 weeks. So the higher the number of positivity before, you'll have the higher chance of being positive after 12 weeks. So if you have all 3 antibodies positive, most likely almost 95% chance after 12 weeks, all of them will be positive. And if it's only 2 or 1, the chance of being positive goes down. Now that's also with another problem in this. If you don't have a clear cut why was the antibody positive before and negative afterwards, for example, many pregnant ladies will have the antibodies positive, but post-pregnancy it will be negative. That's probably a reason to be positive. A lot of patients during the COVID vaccination were positive for these antibodies, and once after you repeat after 12 weeks or after a year, all of them became negative. So was it really just antiphospholipid, or was it because of the immunogenicity of the vaccines we got? That's really a question. On the other hand, those who are positive, many of them with time becomes negative, these antibodies. So there have been abstracts looking at that. But there's no correlation with the disease itself from clinical manifestation. So it doesn't mean that after 12 weeks or 12 months or 18 months, if these antibodies are negative, the risk for VTE has gone. No, it may still persist. So that's why many people will do the antibodies at 12 weeks and repeat it afterwards also. And if they're positive, then they do make the diagnosis. Now, that's really individualized practice. It's not recommended by the guidelines. But then you have to take everything into context. If you miss a diagnosis of antiphospholipid syndrome, it can be really life-threatening for the patients the next time they get a PE. Also, so the more antibodies are positive, the higher chances they develop a cardiac disease or, for example, myocardial infarctions. And the most most antibodies associated with thrombosis are the lupus anticoagulant, followed by anticardiolipin, and the least one is the beta-2 glycoprotein antibodies. So the EULAR also proposed this high-risk profile and low-risk profile, which we do follow. So the high-risk profile is either you have a lupus anticoagulant positive, or a double positive of any combination, or triple positivity, or persistently high titer positive antibodies. And the rest will be low-risk profile. Though we do have that, I'll tell you when we sometimes use these. So treatment of APS, the guidelines from the EULAR in 2019 are one of the best ones, to be honest, and even in the ISTH, American Society of Hematology 2020 guidelines, they're almost very similar, except for the use of DOACs, and I'll tell you that in a minute. So every patient should be risk stratified, whether he's a high profile or low profile. General measures for coexisting other medical comorbidities like smoking, hypercholesterolemia, other cardiovascular diseases should be maximized therapy for those patients. Patient education is very important. As I said in the beginning, most of these patients will be on warfarin, and it's a hassle. Patient education, they have to be aware about the risk of taking it. If they stop it, what's the risk of stopping it? It's very important for these patients. The other part here, so basically primary thromboprophylaxis antiphospholipid positive subjects. So sometimes you get these patients who have the antibodies and never had any poor pregnancy outcomes and never had VTE. And why did they were tested? It's either because a family member was positive, or sometimes just they were ordered by mistake. And what to do in these patients? So many people, or even the guidelines, have mentioned using either recommended or suggested using aspirin in these patients. The evidence is very, very poor, actually. If you look at the evidence they looked at, none of them are actually positive results. Or they were either equal in randomized trials or observational studies, and they're very, very weak. So do we do that? Yes, I do that in high-risk profile antiphospholipid antibody patients, especially lupus anticoagulant. I do offer the patient aspirin as a primary prophylaxis and give them the choice, telling them that it's equal. If you don't want to take it, that's also positive. Giving that, really, we rarely see GI bleedings with aspirin nowadays. So it's really very uncommon to see that. Nonetheless, knowing that these are very weak recommendations overall. So it's the same. For secondary prophylaxis, so secondary means once the patient has already developed a venous thromboembolism, so whether DVT or PE, what to use. So a bottom line of this busy slide is basically warfarin. Vitamin VKA is vitamin K antagonist, and the one we have in our kingdom is warfarin. So the very old 70, 80-year-old medication that we use has been established very well. Recommended INR is 2 to 3. If you have recurrent thrombosis while the INR was therapeutic, and that you really need to underline multiple times, failure of warfarin is very, very rare, except if you have antiphospholipid syndrome active. So you may increase the dose or the therapeutic range to 3 to 4, or you may keep 2 to 3 therapeutic range INR plus low-dose aspirin, or you may switch to enoxaparin. Now, it's a hassle getting injections every day. Sometimes if the patient is 90 kg or 100, it's twice daily. That's very tough. What I do, and it's in accordance to the guidelines, I usually keep INR 2 to 3 plus low-dose aspirin. I prefer doing that rather than increasing the 3 to 4. Very old data published in probably in 2001, 2002, looking at the INR management 2 to 3 versus 3 to 4, there was no difference in thrombosis recurrence, but there was definitely higher bleeding risk in those patients. So what about low-dose aspirin and INR 2 to 3 warfarin? Again, from 2000, very old data in atrial fibrillation patients where there was nothing else apart from warfarin those days, a study called warfarin aspirin recurrent stroke study or WAR study. It showed that whenever you combine aspirin with warfarin, the bleeding risk goes up compared to warfarin alone. So I do pick and choose my patients. So those patients who are above 65, I usually try to avoid adding low-dose aspirin, except if I'm really stuck. For those patients who are younger than that, I explain to them the risks, and I do offer them both approaches, whether increasing the INR or adding low-dose aspirin, and I do prefer the low-dose aspirin, and most of them do choose low-dose aspirin addition. So that's what I do, and that's basically what's mentioned in these two guidelines here. Now, antiphospholipid and arterial thrombosis is a much bigger problem because some of these patients, and we get these consultations from neurology, a young patient with stroke, and one of the thrombophilias is antiphospholipid syndrome. Some of them do come back positive. So what we do, we know that there's conflicting data about low dose of aspirin and venous thrombosis, but we definitely know it works beautifully in arterial thrombosis. Does warfarin work in arterial thrombosis? Again, conflicting data, but anticoagulation per se has been shown to work in acute coronary syndrome, for example, myocardial STEMIs. So most of the authorities do recommend warfarin, usual INR, plus low-dose aspirin, and I'll show you those evidence behind us. Now, obstetrical APS, again, you can go through the guidelines in the beginning. I showed you the reference, but basically, these are patients who have recurrent abortions, intrauterine fetal death, or preeclampsia, and are positive for the lupus anticoagulant antibodies or APS antibodies. From hematology, what we do is usually, and these are the very old recommendations again, but we usually do prophylactic dose enoxaparin, what we have here, although the better data is on dalteparin, which is another low molecular weight inhibitor non-available in Saudi Arabia. So we do enoxaparin prophylactic dose plus low-dose aspirin, which is 80 or 100 milligrams daily. If that's unsuccessful, we increase it to something called intermediate dose, which is 40 twice daily instead of 40 once daily. And if that's unsuccessful, some people would go for full anticoagulation, therapeutic anticoagulation, 1 milligram per kg twice daily or 1.5 milligram per kg twice daily with aspirin. And that's the most we can do. Now, based on some case reports, people have looked at either giving rituximab, giving hydroxychloroquine with low-dose steroids in the first 3 months of gestation. Now, that's very low, weak evidence. I haven't been in a situation where to do that, to be honest. So the biggest question that came up in the last 5-6 years was whether we can use DOACs, so direct oral anticoagulants, which include apixaban, rivaroxaban, dabigatran, edoxaban in these patients. Now, to be honest, dabigatran was the first DOAC to be approved. It works in a different way. It's a direct thrombin inhibitor. It has been fallen out of favor, so a lot of people don't use it anymore, even in other indications, approved indications. So you will not find many data on that. Rivaroxaban and apixaban probably are the commonest one being used in the kingdom here. So what they did, first of all, they looked at dabigatran data from all the VTE trials that they did, and this was a retrospective subgroup analysis, and it showed that it didn't differ much from warfarin. And based on that, rivaroxaban did a similar study, which was the RAPS study. So the primary outcome was percentage change in endogenous thrombin potential, not really looking at clinical outcomes. And there was not many events in that scenario. So But again, there was no red flag that you couldn't use DOACs in those patients. So the famous TRAP study was done, rivaroxaban versus warfarin in high-risk patients with antiphospholipid syndrome. I have to say, for one lesson from this trial, when you start using a new medication, don't use it on the worst patient. You're probably going to get a bad result. So triple positive, I have shown you that the worst case scenario. So they used a new medication on that. And guess what? The study was stopped earlier. There was 9 events in the rivaroxaban arm were 19% compared to 3% the warfarin arm after a year and a half after randomization. And most of these were arterial thrombosis, especially stroke. So by that, there was a warning, actually, not to use DOACs in these patients. Nonetheless, another trial was done, rivaroxaban versus vitamin in antiphospholipid syndrome, a randomized control trial, and approximately 60% had triple APL positivity, 35% had arterial thrombosis. And again, it was a non-inferiority trial, and it was unable to show non-inferiority. So you can't say, okay, so it was non-inferior. It was not non-inferior, so meaning it was inferior to warfarin in that trial. So again, so rivaroxaban was out, and I was amazed, but this was published in 2022, looking at apixaban in a similar population. And for secondary prevention of VTE in APS, we usually use warfarin. That's the ISTH and the American Society of Hematology have recommended that. They don't use DOACs. The EULAR recommendations from 2019 suggested that you may use it in low-risk profile APS, or you can use it if the patient doesn't want to take a warfarin. So I do have a patient that lives around 400 kilometers away from Taif. She follows with us, and it was impossible for her to get INRs done either in her village or nearby hospital. And I basically had to bite the bullet and give her apixaban. That's the one available. 2 minutes? Okay. So that's about the antiphospholipid and thrombosis. What about the arterial thrombosis? Not many data. That's about probably one of the best meta-analysis. And it looked, you won't have much randomized control trial on that, but it really looked at which regimens do we follow in arterial thrombosis: single antiplatelet, dual antiplatelet, antiplatelet and warfarin, or high-intensity warfarin. And probably the best one was single low-dose antiplatelet plus usual strength warfarin. So that's what we use, and that's what we have adopted. Hydroxychloroquine, a lot of interest in it. I learned from rheumatology, Dr. Sami Bahlas, using it in patients with antiphospholipid syndrome with thrombocytopenia. It's a hassle to anticoagulate these patients. And in fact, within a month, it really goes up the platelets, and you can stop it after 6 to 12 months. Statins just to maximize therapy. Catastrophic antiphospholipid syndrome, complex clinical syndrome, multiple organ failures. There have been proposed criteria for definitive and probable catastrophic antiphospholipid. The ISTH, and through the McMaster Rare Best Practice Clinical Practice Guidelines, recommended biopsies to prove that. Honestly, I have seen 2-3 cases throughout the last 15 years. You don't have time to do that biopsy. And you don't need to, honestly, you cannot wait for 2-3 organs to be involved. So you need to start treating them immediately. And what are the options? So anticoagulation with unfractionated heparin, not enoxaparin. Unfractionated heparin, corticosteroids, either a pulse or the 1 to 2 milligram per kg, plasma exchange. Most of the time, we also throw in rituximab. Eculizumab is not available anymore. We haven't used it before. Cyclophosphamide, probably after 3-4 days, or with refractory cases, we may consider it. But better we throw everything up front, and you don't have much except these best clinical practice guideline, which is really based on 8-9 people deciding on the. So the evidence is really weak just because the cases are rare. So that was my talk in a nutshell, and I'll be happy to answer any questions later on. Thank you.